hello, my name is Jack Curry and I'm a student at Midwestern State University. This is my presentation on patients who are undergoing cardiac catheterization and the comparison between vascular closure devices and manual compression when it comes to achieving hemostasis. So cardiovascular disease is the #1 killer of adults worldwide, with coronary artery disease being the #1 offender. To diagnose coronary artery disease, a patient usually goes through the process of coronary angiography in a cardiac cath lab that's just like this one. Here's the X-ray system that we use in the cath lab. This is a patient table, and the physician will view the coronaries onto the screen right here. So, while cardiac catheterization has made some huge strides in the past 50 years, there are major complications that can arise from the procedure. Some of the complications are bleeding, local bleeding. You can have retroperitoneal bleeding. You can have hematoma development. Infection can occur, and even stenosis or closure of the artery. So, for the past 50 years, manual compression has been and remained the gold standard for achieving hemostasis after a cardiac catheterization. Manual compression just consists of holding kind of light pressure right on the access site on the artery for anywhere between 10 to 30 minutes. It just kind of depends however long it takes to achieve hemostasis. And over the past decade, a range of what they call vascular closure devices have been created, and these have some benefits, but there are some complications too that we'll talk about. So I'm just going to show you a few that we use here in our cath lab. This one is called AngioSeal, and this one is collagen plug. This one is Minx, and this one also is a collagen plug. They're just kind of two different ones. And this one is called Perclose, and this one is a suture that goes inside of the artery and closes it up that way through a suture. But there's quite a bit of evidence that while these are very good and work most of the time, there are some complications that can occur with those. But I want to talk a little bit first about the types of different vascular closure devices are. So I did show you some of the collagen plugs, the sutures, but there's also clips, gels, patches, and they are very effective. So the reason why I want to talk about this subject is in interventional cardiac radiology for the past 50 years, we still have a lot of what I call like old-timer type physicians in the field. And some of these guys just kind of have, an older kind of mindset. And sometimes they take kind of unnecessary risks towards their patients. A lot of times they're just sticking a whole bunch of times blindly trying to get access, and that increases risks to the patient. And ultimately it's the nurse who is responsible for the safety of the patients. It's our responsibility to be aware of complications that can occur, patients who are just genuinely at higher risk for complications, and the nurse is the perfect person to hold manual compression on these patients who are at higher risk. And another thing to note is with these vascular closure devices, they actually recommend manual compression with the use of these things. So a little brief discussion about risk factors, I guess we would call them. So there's patient-specific factors, and these are going to be things like advanced age, female, gender, patients who are extremely underweight or extremely overweight. Those are going to put them at higher risk for these vascular complications that I was talking about. Clinical factors are going to be things like a history of hypertension, diabetes, peripheral vascular disease, renal failure, those types of things. And then there are factors that are specific to the procedure itself, and these things are like techniques that are used, the number of puncture attempts, the sheath size that's put in, was there use of anticoagulants, and the method to achieve hemostasis, and then of course nursing care. So what I have developed here is a problem statement, and it's basically in patients undergoing cardiac catheterization, how does vascular closure devices compared to manual compression affect the prevalence of post-procedure complications? So in my review of the literature, so I did some research, and I found quite a few different things that are going to discuss what I'm talking about. That basically I think it's just a good idea to use manual compression on every patient, no matter if these are used or not. One study that I have found just did a kind of a blanket study on all these different manual compression, on all these vascular compression devices, and they had several different endpoints that they were studying, and anything from how long did it take to achieve hemostasis, how long did it take for the patient to be able to ambulate, what was the patient comfort levels, were there complications, those types of things. And so while I said there's definitely no doubt that these devices do offer significant advantages in specifically how long it takes to achieve hemostasis and how long it takes for the patient to be able to ambulate is much shorter when you use these devices. But the studies also show that there are significant complications that can arise when we use these things. A lot of times these things, even when we do use them, they actually fail. So they don't really do what they were supposed to do because they're prone to device failure. And when they do, it's manual compression is what you're supposed to do to fix that. So there was another study that examines the pros and cons of both vascular closure devices and manual compression. These authors determined that manual compression has basically a nearly 100% success rate when it's done appropriately. It's obviously much easier to do. It's cheaper because you can do it with skilled labor. There's not, you don't have to buy these expensive devices. So while I said that VCDs do offer a quicker time to hemostasis and sometimes ambulation, if they fail and you have to keep using them, overall they really might not be that much faster than just holding manual compression. I would like to talk about another case study that was done on this one. This one's called AngioSeal, and this is one of those collagen plugs I talked about. This study determined that AngioSeal was one of the reasons that a patient developed what was called infectious arteritis after recurrent hemorrhaging from use of this vascular closure device. So it basically stated that after 19 days after the surgery, the patient was readmitted to the clinic with symptoms of a ruptured aneurysm in the right groin that became necrotic. The patient had to go through a surgical procedure, and they suffered many subsequent hemorrhages, which resulted in further hospitalization and further surgical procedures. And ultimately, this patient did develop infectious arteritis, which became septic. Okay, so another study that was done on this one, Mink script, which is another one of those vascular closure devices that I talked about that uses a collagen plug, stated that it is in fact a very effective tool used to achieve hemostasis. However, when if large bleeding or hematoma developed, manual compression was the action that needed to be taken to stop that bleeding, not more of this. And it also found that Mink script, while it does shorten the time to hemostasis, that there is an increased risk for groin infection, arterial stenosis, and lower limb ischemia. So another one done on this one, Perclose. And this is the suture-mediated vascular closure device that I talked about. So this was another just case study, and it was associated with stenosis of the common femoral artery. It was a 74-year-old man who had intermittent claudication. He underwent an atherectomy with balloon angioplasty for the stenosis of the left superficial femoral artery. When Perclose was used at the end of the case, hemostasis was achieved and the patient was discharged without complication. However, a week later, the patient returned for pain in his thigh and his right leg. After angiography was performed, it was shown that the patient had developed a near complete occlusion of the right common femoral artery. It says that the specifics of how it happened are complicated, but it was shown that it was a result of the suture-mediated VCD Perclose. Let's see. Another study, this one was done in 22. It was talked about a 73-year-old man. He had drug refractory chronic AFib. He underwent a pulmonary vein isolation via ablation. 2 weeks after the patient had the procedure, he developed a lower right leg edema. A venogram showed that limited flow due to stenosis of the right external iliac vein. The patient needed further catheterization and balloon angioplasty to return flow. So he just needed more procedures to fix like a problem that happened in the first procedure that really shouldn't have never happened. And they found that in this case, the stenosis was caused by the physical stitches that were put into place by the Perclose. So those were just some of the case studies that I found and some of the research that I found. I'd like to talk about a proposal plan description. This would be, how I would propose, my, what I think would be a good idea to the hospital or to other stakeholders. Speaking of stakeholders, so the stakeholders in this one are going to be your patients, hospitals and clinics, the physicians, the nurses, and of course the VCD manufacturing companies. For patients, there are some benefits and some drawbacks. The patient will benefit because there will be a decreased risk of complications. They'll also benefit by a decreased likelihood that they would need to be re-hospitalized and decreasing further medical expenses. The drawback of always using manual compression is that it does take a longer time to achieve hemostasis, and there's a longer time until they can ambulate, and there may be some discomfort when applying manual compression, especially if you have to do it for 20 to 30 minutes. But this could be minimized with concurrent use of a VCD, so basically using the VCD as well as manual compression. Hospitals and clinics, they're another stakeholder in this proposal. They're going to benefit by the fact that VCDs are very expensive. so we can, reduce the costs of healthcare by using fewer of these, and then of course reducing the risk that patients incur, from the complications of using them. And then of course, in that sense, there would be a decreased cost of care for hospitals. And hospitals will benefit because there will be better patient outcomes. Physicians can benefit from this proposal by achieving better patient outcomes and fewer repeat customers due to complications. Nurses benefit because they can provide safe and effective care for their patients. There may be a need for additional nursing resources because it does take manpower to do this. VCD manufacturers will have a less optimistic opinion because they're going to lose money due to the fact that we would be using less of their product. Implementation of the proposal would be done using a mixture of technology and human resources. Implementation would be paying attention to multiple factors. We would use evidence-based interventions coupled alongside input from employees. Employees' concerns should be heard. They should be acknowledged through frequent formal and informal meetings. Teams should be established in planning and implementing the change. In addition, expectations should be managed about the change. And there should be educational campaigns that would be held for all stakeholders involved. The impact that this change could have on healthcare is that it will require a stronger nursing presence, since the holding of manual pressure is time consuming and it must be done by a skilled nurse. Hospitals will benefit twofold from better healthcare outcomes, resulting in fewer rehospitalizations, and reduced costs from using fewer expensive vascular closure devices. Education will be needed for nurses who are coming to work in the cath lab on how to apply appropriate compression. And patients are probably going to need a little bit of education as well, discussing why it's better to hold manual compression for them as opposed to using the vascular closure devices. There may be some barriers in implementing this change. Certain things like holding manual pressure is not an exactly attractive task. Nurses don't love doing it because it does take so long. It's kind of tiring. Your muscles kind of wear down while you're holding that pressure for that amount of time. Other barriers could be, patients are not going to love it because, as I said before, it does take longer to achieve hemostasis. So, they just may not see the benefit of holding manual compression over the vascular closure device if they have to wait so much longer for it to happen, and much longer for the recovery process afterwards. So some of these things, if we were to implement this in my facility, it would, there would be a need for some evaluation of how things are going. So we would need to know what the expected outcomes are. Outcomes are going to be a reduced incidence of post-procedure complications, such as the localized bleeding, the retroperitoneal bleeding, hematoma development, and other more serious complications. So we would definitely see a decrease in those types of things. Another expected outcome is there should be a decrease in rehospitalizations and the associated costs with those. We could, the way we would collect data is through, document analysis, which is gathered from applications and finances and other memos. We could conduct surveys, such as participant questionnaires. We could do patient interviews, which would provide valuable feedback. There could be focus groups that are, documented questions that would be, asked in a group atmosphere. And then case studies along the way, on individual patients. And there would be barriers to that as well. You know, not every organization is going to feel like there really needs to be a change. Some practitioners are probably not going to be interested in doing this for sure. And there could be disinterest from the participants as well. But you know, to get this information out, we could use, you know, just in my facility alone, we could put up bulletin boards in the break room, and the procedural rooms, and other areas where there's high flow of individuals, such you know as the nurses and clinicians. We could do in-services, you know, which could be a helpful way to educate the staff. I could do a YouTube presentation, such as what I'm doing right now. You know, and to get this out into a broader realm, you know, and especially in like the academic world, we could provide findings, you know, of what we find, you know, here at my organization to national journals and statewide publications. We could present the information at national or local conventions and conferences, and could spread the information beyond the level of the organization. So, you know, in conclusion, again, you know, I mentioned that cardiovascular disease is the leading cause of death worldwide in adults. And, you know, while there are major advances into treating that, you know, all those complications still do exist, and we have to consider what patients are at higher risk, and we just need to be aware of those, especially as nurses. And, you know, while we do have these types of products that have really come a long way in providing great patient care, and especially in allowing patients to have, you know, a higher level of comfort, achieving hemostasis quicker, achieving the ability to ambulate quicker, we just have to be aware that these do have their fallbacks as well. And, you know, and there's no shame in just reverting back to good old manual compression anytime that it's needed. So thank you for listening to my presentation. I hope you learned something.